Thank you very much for the kind introduction, Professor Madesbacher. I would like to thank the organization and the INES to give me the opportunity to stand here and to tell you a little bit about brain control of the lower urinary tract. I think it's important to know something about it, because if you look at urology 30 years ago, what was the main practice at that time? Stone surgery, TURP, orchidofixatie in children, and also at our department for urinary incontinence, we did a lot of sphincters 10 years ago, and also a lot of urinary diversions. 10 years ago we did about per year for functional problems about 40 diversions at our department. Now we do only 2 or 3 diversions per year. And that's all because there's a shift from surgery to more a functional treatment, like sacral neuromodulation. I think also botulinum toxin is a functional treatment, and many, many other possibilities. And we can only do and design those treatments because we know that the bladder is not the bladder only, and the prostate is not the prostate only, and the erections are not erections only, but there is a connection usually to the rest of the body and mainly to the central nervous system. These are my disclosures. So, neurocontrol of the bladder. I will tell you a little bit about what we know due to the last 2 decades. We know a lot about the mechanism of action of the control of the urinary bladder. And what can we expect for the next 5 years? First, it's a picture from the Growth Group, Pittsburgh, and they showed that afferent information, sensory information, is entering the dorsal horn in the sacral cord, and the parasympathetic neurons are located in the mediolateral cell column at the sacral cord. Then the next step was how to show how the brain controls the bladder and the urinary sphincter. So my supervisor in Groningen, where I worked before, showed that when you make an injection in the Barrington's area, you nicely can show with antegrade tracing that there is a direct projection to the parasympathetic motor neurons of the bladder. When you inject a more lateral area, it can be shown in the pons, and this is in the cat, that there's a direct projection to the pelvic floor motor neurons. When you put an electrode in the brain, in the pons, in the medial part, you get full-blown micturition. Every time you stimulate, you get first the relaxation of the urethral sphincter, and this is followed by a contraction of the bladder. And that's normal micturition. When you are stimulating in the more lateral area, this area where the pontine continence center is, every time you stimulate, you get a somewhat relaxation of the bladder and the forceful contraction of the pelvic floor and the urethral sphincter. When you destroy the area, the micturition center on both sides, you have a chronic retent cat, and when you destroy the lateral area, the pontine continence center, you have an extreme urge incontinent cat. At that time it was not known how the relaxation during micturition takes place. 10 years later, I was in Groningen and we did a few experiments with the electron microscope, and we showed that direct projections from the pontine micturition center are ending on an area medial in the sacral cord and containing glycinergic and GABAergic grains, meaning that the connection from the pontine micturition center goes to inhibitory cells, which in turn relax the urethral sphincter motor neurons. And this is shown here when you stimulate the sacral cord on the right place, medial on the sacral gray matter, every time you stimulate, you get a relaxation of the urethral sphincter. Very nicely. So we proposed for the first time in the world at that time how normal micturition takes place. When you stimulate the pontine micturition center, there is a contraction of the bladder via the bladder motor neurons, but at the same time, via inhibitory interneurons, there is a relaxation of the sphincter. And the relaxation of the sphincter is much faster because it is a striated muscle. And the contraction of the bladder is much slower because it's smooth muscle. And that's why the excitation of the both groups is at the same time, but relaxation of striated muscle is much quicker. And it's followed in 1.5 seconds, also in humans, by contraction and evacuation of urine. We took that up and we showed also that projections in cats are not directly from the sacral cord, are directly to the pontine micturition center, but they are to another area in the midbrain periaqueductal gray. And we showed, I don't explain that for the rest, that sensory information from the bladder is relayed to the periaqueductal gray. And when the signal in the human is safe to void, you can void. If the signal is not safe, you get a no-go signal and the micturition is blocked. That explains why women who are sexually abused have very much difficulty in spontaneous voiding. And it's the same with the bowel movement. They have very much difficulty, sexually abused persons with bowel movement, because the system says it's not safe to lose your excrements, stop it. And what is happening, the system, the cerebral cortex says, stop voiding. So we took that model in the late 90s to the human situation, and there was PET scanning, dynamic brain imaging, and later was functional 1.5 Tesla and 3 Tesla. And we took the model that we designed in the cat to the human situation, and it was shown in 97 that every time people micturate, there's an activation of the human pontine micturition center, and also at the same time in the periaqueductal gray. So here's the pontine micturition center, and here's the periaqueductal gray. We showed it both in men, and this is the picture from women, that during micturition there's activation in the neurons of the pontine micturition center. At the same time, 40% of the women could not void, and the system says, stop, withhold your urine. And there's an activation of the pontine storage center, and in that way, the pelvic floor is squeezed and you can't start micturition. There are, in essence, in my view, 3 main groups in the brain imaging. That's Pittsburgh, the group from London with Claire Fowler, and our group. And Edwell from the group in London with Fowler, they showed when you fill the bladder, you see a major activation of the periaqueductal gray, showing that the concept in humans of the involvement of the periaqueductal gray during micturition, during bladder control, is valid. Later on, Derek Griffiths, mainly from Pittsburgh, showed with functional MRI that indeed the dorsal, the pons with the micturition center, the PAG, is active during micturition and during bladder filling, and also the emotional cortex with the cingulate gyrus and the prefrontal cortex here is important for normal micturition. The problem with those imaging studies is that they're done only in small groups. There are several studies without a control, And usually they use a low threshold because dynamic imaging is all about statistics, because you compare one image during a task with a control image during rest usually. So you do a subtraction statistics, and so you can play with the threshold until you have the right result. So always look careful to all those nice pictures because in my view they totally depend on the thing you want to see. So usually they have low activation, which doesn't say a lot, without a model. And that's the problem in psychology. They don't have an animal model, so they can say anything about the activations they see in psychology or psychiatry, but it's very difficult to argument that the statements are right without an animal model. And the studies in bladder dysfunction, they have little clinical impact. This is an example of Griffith in 2015. They showed that people are treated after physiotherapy, and what do you see? People are more conscious about the contraction, and here's activation of the motor cortex after physiotherapy, quite logic, I think. And what you see, a deactivation, blue is deactivation in the prefrontal cortex. That means they have less urge to do something, in this case, less urge to void. So that's the effect of physiotherapy. And we showed with neuromodulation that neuromodulation modulates the areas important in the decision whether to void or not. So it suppresses the urge to void. The problems with the functional MRI in 2015, it doesn't have a big resolution, 1.5 and 3 Tesla. You can't do any imaging in an individual subject. You always must summate 10 patients or 10 volunteers to have a significant activation. And there's no valid biomarker for bladder dysfunction. And you can't say anything about individual patients. If you look at the progress of MRI, and this picture shows the emergence of MRI. This is 0 Tesla. It started in the late 70s. And then 5 Tesla cameras emerged in 1990. And then 7 Tesla in 2000. And it went up. And it is expected that in hospitals in 2020 there are many more 7 Tesla cameras. But you see there's an S-curve. It saturates. Above this level, above 14 Tesla, in my view, it doesn't make much sense because 14 Tesla is extremely sensitive to movement disorders. You can understand that. So what we did in our hospital, we looked with 7 Tesla, and the advantage is you can have significant activation in individual subjects, much higher spatial resolution, and you can have, when you prove that it's valid in volunteers, you have a clinical relevance. So most of the techniques use, it's shown here. Let's see. A single spool, you put it on the brain, and only a limited area you can visualize. So the rest of the brain is out of focus. You can't say anything. So it's very neat for visual stimuli. But for deeper areas, it's difficult to say anything. So we used a totally new method, not used in 7 Tesla usually, and that was a whole brain imaging. And there you can see from the cerebellum towards the frontal cortex and the prefrontal cortex, the whole brain, and you can look at it in the whole context of the lower urinary tract, not only a single area, like NIRS. There's another technique which only looks at the surface. We did a few scans, tactile stimulation of the genitals, repetitive pelvic straining, tactile stimulation of the medial foot, because PTNS, tibialis posterior stimulation, is at that area, and as a controlled tongue movement. And what you see is that it's very separated. The foot left is close to the area of the penile shaft, but separated, and not in this area fused. So you can interpret it that when you stimulate the penile shaft or the urogenital area with sacral neuromodulation, it's until this level is separated from PTNS stimulation. Only later it fuses. So it doesn't, in my view, relate or works directly on the micturition reflex components, PTNS or sacral neuromodulation. And this is pelvic floor contraction. It's more ventral or more rostral in the motor cortex and the premotor cortex shown here. Also, the technique shows that you can very efficiently show activation in the cerebellum. This is one person, and you see tongue movement, penile shaft sensation, and the foot sensation. So very separated. So it means that the technique is absolutely valid, and now we can go to use it for clinical fashion. But it's at this moment, a very difficult technique and very sensitive to movement. We had to do much more patients or volunteers than we expected. We have now valid data from 10 persons, but I think we had 25 persons in the scan. With the PET scanning, when I had to do that with only 30% of the volunteers with a good result, it would be too much expensive, and I never could have done the experiments. So in the near future, 7 Tesla can detect changes in the individual patient, and biomarkers have to be validated internally and externally. We are in the progress of making a risk prediction model for functional disorders. At our department, we made the prediction model for the prostate cancer. And the same people who are building with me the prediction model, the PRIAS and the ASPC model with Monique Robel and Fritz Schröder, the same people who built that model are building now the model for non-oncological problems. So you can validate every technique in that. So the take-home messages. There has been much progress in the mechanism of actions of the control of the lower urinary tract, but very little impact. Better bladder dysfunction outcome, I'm convinced that it needs a multimodal approach. Both the knowledge from oncology, non-oncology, functional urology, neuroscience must come together to have a valid impact. And biomarkers, brain biomarkers in single subject have to be validated in an outcome model together with patient-reported outcome measurements. So you can link them together, and in that way you can stratify your patients with mild, moderate, and serious complaints. So I must acknowledge my co-workers of the group in Rotterdam, Sven Luiten, Johan Holstegen, who is actually the brother of Gert Holstegen, my supervisor. So Chris de Zeel, the chair of the department, several PhD students, Monique Robel from the oncology department, and the Spinoza Center in Amsterdam at the Academic Medical Center. And I must also thank all my international colleagues who always helped me with the progress. And again, like my colleague, Professor Madersbacher, I want to invite you at the neurourology meeting from 25 to 28 January in Zurich. Thank you very much.